All right. So now we're switching back over to theory. We're going to the Cvads. So what's a Cvad?
A central
venous access device.
Central venous access device. Good. So what I need you to do by the end is be able to talk about the different types, the complications, the appropriate nursing management for the different kinds. So you'll also hear it called the CVC, central venous catheter. We use them for chemo, blood, long-term antibiotics. People go home with them if they're on chemo and long-term antibiotics. Again, we talked about TPN, they have to go in. And then what's a vesicant? Anything that's irritating to the vessel needs to go in through a central venous catheter. Remember I talked about the blood flow being much more turbulent there, so it doesn't sit the way it does in a peripheral line.
So anything that has to go through what? The last word.
The vesicant is just anything that would irritate a vein.
Okay.
So something that would be caustic can go in through a CVC because the movement of the blood where that goes into that superior vena cava is moving so fast that it's not sitting there and able to burn the vein the way it would in a peripheral. Sometimes we need immediate access and they don't have veins and it's an emergent thing, so they'll put the CVC in. If we have somebody who is getting venipuncture like Q2 hours or something, obviously that's not cool, so we'll ask for some sort of CVC, whether it's like even just a midline or, which isn't technically a CVC, but PICC line, whatever. Hemodialysis, we do the central venous catheters. They usually will have, you know, like your patient, and we'll talk about this on test 4, but when your patient gets like a fistula done, you can't use that immediately. It has to heal, right? So they'll temporarily use like a tunneled catheter, which we'll talk about. Complications, sepsis is the most common. Have you guys all seen the bio patch that goes on the dressing? Has everybody changed a central venous catheter dressing?
No.
You're not allowed at Baker? Oh. Well, at Bayfront we'll change them. Find out if you are allowed, if it's just the instructor that wouldn't let you, because if you're allowed, it would be nice. They are? The central venous dressing? Yeah. So try and, this semester, if you haven't done one, try and find one that needs to be done. So I know most places have like a team that does them, or they do them like every Sunday night or something, right? So when are some other times that you're going to change that dressing though? If it's soiled, if it just looks cruddy and it's all peeling up and there's dried blood under there, a lot of times the IJs from everybody moving, they get all weird and gross. So anytime it's open to the air too, you don't want that. So, you know, just walk down the hallway and do your 60-second assessment on everyone. Hopefully you'll find one that needs to be changed. When we're changing them, you guys, I think this was level 3, right? You guys had the level 3, that was one of your checkoffs. So we know it's completely sterile. Make sure that you and your patient both have on masks. I always make them wear a mask. I never ask because, you know, they say if your patient can't turn their head, I'm not even going to take the chance that he's going to turn and start talking to me, so I just make everybody put on a mask. So what happens if your patient does become septic and they have a central line? Remove it, right? Especially if we don't know why they're septic. If we don't know the cause for the infection, if we're just doing cultures of everything, they're going to pull that, they're going to cut the tip of it, and they're going to send it to the lab to culture the tip to make sure it wasn't the actual catheter causing the sepsis. What happens if you walk into a patient's room to do your assessment and the site where their line's going in is all like crusty and yellow and gross?
Notify and clean it.
Are you going to clean it? Yeah, you're going to culture it. So normally, before you clean it, call the doctor and just say, hey, this isn't looking so hot. It looks like maybe it could be infected. Because they're probably going to want you to culture the site even before you pull it, but then you culture the site and they're going to probably want to culture the tip too. So if it looks infected in any way, don't clean it until after you talk to the doctor. An air embolism. So that just means the air somehow got into the catheter and then into the circulatory system. So how does that happen?
When you was flushing it, you had air.
Maybe when you're flushing it, changing the cap. So anytime, not so much when you're flushing it probably, because I mean, I hope everybody's pushing the air bubbles out and stuff, but whenever you're taking the caps off to change them, make sure that they're locked. Make sure if your line's not being used that it's locked, right? Thrombus, so over time, let me see if any of these guys will pull up for me. Sometimes they do. Over time, at the end of the tip of the catheter, especially if it's not being used regularly, it can get little baby clots on it. What happens when a little baby clot forms? The blood cells stick to it, it becomes a bigger clot, right? Usually I have one separate that I can show you. I'd like to show you the different lumens. Let's see if I can. They have these all tied in knots in here. I'm gonna untie it. Oh, but this is only a single lumen. All right, I'll find a double lumen too. So the clots will form, and if they're not being flushed regularly as they get bigger and bigger, those can break off and end up in the circulatory system, right? So that's why now you're supposed to flush every line, every shift. It's now even on all of our MARs, right? We used to all just carry flushes with us and flush them. But now it's actually even on the MAR to make sure they're getting flushed every shift. If there's 3 different lumens, you're doing 3 different flushes, right? You're not just flushing one and saying, oh, that's good. Because each time that there's a little, when I find one eventually, if there's openings at the end of all of them. So before we're putting anything into any of these lines, and we'll go through the different types in a few minutes, we're going to make sure that they're patent, right? So also at the beginning of every shift, or when you're flushing it on every shift, you're going to pull back, make sure that you're getting blood, make sure that it's flushing okay. Anytime you pull blood off these lines, I make it a habit just to go ahead and change the tip, because if you really look, oh, this one's not clear. So some of them are clear and you can see the blood just sits in there. So grab a tip if you're pulling blood off, and you can switch it out, make sure it's locked first. So what size syringe are we using? 10. Why?
Because anything smaller, you're going to puncture or rupture the...
Yeah, so think about your little 3cc syringe. It's super easy to push, right? You push it and it goes quick. And you can like get 3 cc's and just push it, and I could probably hit you back there with it, right? Like really quick. Lots of pressure. So that could blow out one of these lines. They're tiny. They're not, you know, the thickest line. So we want to make sure to flush, and really anything we're putting into one of these lines should never be put in with anything less than a 10 cc or 10 ml syringe. Okay? So the different types, we have a PICC line. So that's your peripherally inserted one. So even though it's going into a peripheral vein, it's going up in that vein, up into the superior vena cava, right? So it's still going to the same place that your IJ or subclavian's going. It's just taking a longer time to get there, right? Tunneled, or non-tunneled rather, would be like that IJ or the subclavian. We see a lot of those. And that's just depending, the subclavian's going into the subclavian, down into the superior vena cava. The IJ is going into the anterior jugular, EJ. But those are going directly into larger veins. It's closer to the heart. You have a higher chance of infection happening because it's right there instead of having to travel, right? So that's why we use those bio patches, because it kind of prevents anything that does get around that area. Hopefully it'll kill it before it gets in. Tunneled, and you probably can't see it from where you're sitting. Has anybody seen a tunneled catheter in the hospital? So they come out kind of further down here, but you can see them or feel them usually. And so they're going into the same exact place like a subclavian's going into, but instead of me just puncturing there and putting it in, they puncture further down here. They go under the muscle and then it goes in. They have a less chance of getting infection. There's usually a little Dacron cuff that goes right under the skin to keep it in, but also that prevents any infection. It's usually a longer term that they leave these in for. And then the implanted ports, you'll also be able to feel one in this guy over here. If I peel his chest off, you can see it. So this is what it actually looks like. You guys can come up and look at them when we're done. Under the skin, it's a little button. It's actually a surgical procedure. You go in, the doctor makes a little slice there. They go right in under and they implant it. Same thing though, it's going right down into the same area. And then we wait for that to heal, and then it's a special needle, which we'll talk about for these. But this is really great for like teenagers going through chemo, because if they still want to go to the beach with their friends, they don't have to worry about covering this up. You can't really see it as well as you can any of the other ones, right? You can shower with this as long as it's not accessed. So it gives them a little more privacy, especially for those patients with the body issues. Usually it's patients who are getting long-term antibiotics or chemo. Yeah.
Like normal cancer patients who have that.
What's that? Cancer patients, yeah. So you see a lot of cancer patients with these. And the needle that we use, I'll show you a picture in a minute. It's on another slide. It's a 90-degree angle, and it goes right in. You just kind of feel for it, get the two sides, and then you poke it in. You guys are not going to be accessing these. You need training to access these, so you will not access these. Multi-lumen, single lumen, right? That just means like this is a single lumen. When I say it's a double or triple lumen, it has the different ones coming off. Usually it's like red, blue, and gray. I don't know what the hospitals are using right now, but those are the colors you usually see. As a matter of fact, I don't even know what this is. This is a new cap.
They have like
the alcohol. Yeah, I just figured, but we use the green ones. Is this what Baker uses now, the blue ones? Oh, okay. So when we have the different lumens, if you look at the end, there's a little hole. It doesn't come out the tip. It comes out when you push it in. There's a little hole down here that it's coming out of. So if it has triple lumen, if I cut that and I look at the end of it, probably under a microscope because it's so tiny, there's actually 3 different tubes in there. So if you're pushing something into one, it's not mixing with the medicines going in the other. So you can use those for medicines that wouldn't normally be compatible, thank you. Wouldn't normally be compatible because again, the turbulence of the blood right there, it's not going to sit and mix, right? So it's moving quick enough that even if you have it going 3 different medicines that wouldn't normally be compatible going into a triple lumen, it's fine because it's moving so fast it's pushing them away from each other. The Groshong, the slip valve, it's different. It just, instead of, you don't have to, like it's a self-sealing valve. So just know that it's a slit valve. Here's a picture of the different lumens, if you can see up there, and the little arrows point to the different places where it comes out. Again, different meds that wouldn't normally be compatible can go in. Usually, you want to make sure that you're labeling what's going in where. Usually, sometimes, and depending on which ones they're using, it'll say, this says not for human or animal use. I'm going to find that's on my list of things to do on break. Find a triple lumen so you guys can see it. I'm not eating tonight, apparently. So normally, like I said, they go into the subclavian, the jugular, the femoral. It can go into the femoral vein. Risk of pneumothorax, like I talked about with the TPN, that's usually when we would see the risk for the pneumo. When we talk about it during the TPN would be when they're putting in the central venous catheter. And then you can't put one in, but if a PA or NP has the training, they can put it in. Otherwise, it's always inserted by a physician. If you get to watch them put one in, watch it. It's crazy. They do it so fast, and I feel like feel like it's kind of like the thoracentesis and stuff where there's no way they can be numb yet, and they go in with this huge needle. Yeah.
Yeah, but they have IV nurses, like the IV team.
Mm-hmm. So the PIC team, can put in PIC lines and midlines.
Yeah.
Mm-hmm. They don't put in central venous catheters unless they just started, maybe with special training. Because I know as a nurse practitioner, I have to have special training if I wanted to put one in.
So a PIC line is not a type of central venous catheter?
It is, but because it's put in through a peripheral vein, and they do it under ultrasounds, so they make sure, and anytime any of these are done, we're going to get an x-ray. Unless it's a PIC line being done under ultrasound, they might tell you it's okay to use it without an x-ray because they have watched it go in, and they know exactly where it's sitting. Midline is the same thing. It's going to go in peripherally. It's just not going to go in as far, so it might stop up here somewhere. Okay? Chest x-ray always. So this is the PIC line. Can be placed by a specialty trained nurse. Inserted through the basilic or the cephalic vein. It's up to 60 centimeters in length. Usually the ones that I've ever pulled have been in the high 30s, low 40s, so like 37 to 41 centimeters. So one of the things that you need to do is if you have an order to pull the PIC line, you need to make sure that when you pull it, you look at there's dots on it. So it'll say like 35 centimeters, and then for 36, 37, 38, 39, there's going to be dots, and then it'll say 40. So you need to look and see how long it is, and then go back in the patient's chart and make sure that it's the same length and nothing has broken off in the patient. So that's one of the things you have to do if you're pulling them. And then you have to apply pressure, whatever the policy is at your facility. No risk of pneumo because they're not putting a huge needle in anywhere near the lung. It's going in down here. Lower infection risk because, again, it's not going directly into the big veins and arteries up here. It's going further down before it gets in, so the bacteria would have to travel further. And we use the bio patches. And a lot of times if we're going to send somebody home with IV antibiotics, it's the PIC line that they'll end up going home with, not usually a CVC. Dressing, change, and flush are in accordance with agency protocol. It used to be like every 3 days. Now I think most places are every 7 days as far as dressings go. Some places the IV or PIC team is the one who does the dressing. Some places the nurses do it, but they do it every Sunday night on night shift. So it's going to be different at every facility. Again, if you guys get the chance and you find one that needs to be dressed because it's dirty or peeling or whatever, take the chance and do it. Like, just grab either one of us, whoever you're with, or one of the nurses, and just make sure that they're okay with you doing it, and then we can do it. If your patient has a PIC line and they want to take a shower, and we get the order from the doctor to take them off telling and let them shower, I usually take one of the specimen bags and slide it up over their arm and then tape the heck out of the top and the bottom, so that way they're completely covered. We're not going to be doing any blood pressures on that arm. And then we already talked about any signs of crusty yellow, green, red, puffy. We're going to call the doctor. That way we can culture, pull it, and snip the tip. This is a picture of a guy with a tunnel catheter. So see how it's not up as high as we normally see it? It's further down. And you can kind of see under his skin right there, you can kind of see the little bump. It's not a very clear picture probably. I think that picture might be in your book though. But you can come up here and look at this later. It shows it pretty well. So even though it's going in down here and there's a little cuff, it actually isn't going into the actual vein until it gets further up. So it's through that muscle that it's hanging out, and then it has that cuff, so it's just less chance of a infection. With tunnel catheters, everything's exactly the same as far as cleaning, dressings. Actually, a lot of times they don't even dress them. Again, per facility though. Flushing, everything's the same. It shows you there. See how it's not in the vein until it gets further up, so it's just kind of under the muscle until it gets further up. So the implanted infusion port, we talked about chemotherapy, TPN, frequent blood sampling. They would never put one in for frequent blood sampling. Like, they would never be like, oh, we've stuck this lady 4 times in the last 2 days. Let's go ahead and give her an implanted port. So that's not going to happen. But, guys, arm fell off. We talked about how it's inserted into a little pocket in the chest. So that's the picture of the Huber needle, the one that has the yellow butterfly wings. See how it would sit directly on the chest, but it's like a 90-degree angle because the needle is coming directly out of it. So it's a 90 degree because it's going to sit on the chest with the needle going down. The picture. So you would find, like I said, either side, and then insert it, clean it, obviously, insert it. Sometimes they go right in, sometimes they're really hard to get in, sometimes you have to really feel around, because sometimes people have them and they flip, and so, but the patients almost always know their own ports. So they'll be able to tell you exactly what you need to do to be able to access that port, because they've probably dealt with it forever. So they'll tell you, hey, it's really hard, just don't worry, it'll be fine. Usually you don't use anything, but I'm sure like with babies, or peds, they probably could use like the EMLA cream, the stuff they put on before they do the venipuncture. Talked about that.
How long is a port good for? Forever?
Which kind of port? Like this one?
Yeah.
I don't know. I would say it depends on the doctor and what they feel. What's the longest you guys have seen patients with ports?
Until they have a defect.
Yeah, because I wanted to say a year is usually the cutoff, but I know that there are people who have them in longer. But I don't know what like the maximum. I'm sure that the actual company who makes the ports have to put, they have to put some. Is that what it says? Yeah. So less than 2 years is what the company determines. It'd be interesting if they had like a expiration date on it or something. Yeah. So, well, hopefully after 2 years. I mean, 2 years is a long time for someone to be on chemo or something.
Are you trying to say they should be dead by then?
No, they shouldn't be dead, but hopefully their treatments are done by then, right? I don't know.
I don't know if it's for comfort and not really the cure.
That's true.
They might be on it longer.
That's true. That's true. We talked about this stuff. The smaller syringes, no good. Flush the ports, every port, every use. And with this port, the normal saline will be flushed just like normal. You're going to flush it before you use it just to make sure it's patent. And then this says, and then with a heparin flush solution. So I'm going to say that that's per your policy of your company, because most of the time, the only time you're going to insert heparin into anybody that you're not giving it sub-Q or as a drip is going to be if you are deaccessing one of these, they'll heparin lock it. So they'll have you flush it with heparin and then pull the needle so that the heparin stays in the line to prevent it from clotting. And even at that point, so it used to be that we would sash everybody, right? We would do saline, antibiotic, saline, heparin. So we would hep lock everybody. You know how you guys now saline lock everybody? Everybody was hep locked. And then that whole Dennis Quaid thing happened. If you haven't watched the video in your rolls, you will. So now the only time you get heparin on the floor in a flush, it's in the Pyxis or McKesson or whatever they use there, and it's in there by specifically your patient, and it's sent up specifically like on the MAR to flush this or to flush whatever you're flushing. So we don't just have them laying around. Like literally, we used to go to the supply closet and open it, and it was a huge thing of saline and a huge thing of heparin, and the heparin was yellow, and we would stuff one pocket with heparin, one pocket with saline. That's how we would walk around. So now the only time you're using it, like I said, it's usually sent up specific to that patient. And usually with these even, we only flush them when we're deaccessing. So strict aseptic technique, you guys know that from last semester. Every 3 to 7 days per hospital policy. Most of them now are up to that 7 days because they've shown that it doesn't prevent any more infections to go for the 7 days. But you're also going to do it, like I said, anytime that they get dirty, that they're starting to roll off, that the air's getting in. What do you think swelling of the jaw and neck pain on that same side of the catheter might indicate?
Washing up, or is it exclusive? Like it's closing up or something?
Wrong placement.
So it could have actually started backing out and it's coiling under the skin, or maybe when it's going in, there's some sort of slit or something that happens because it's man-made. You think that they're all 100% no anything, right? Our gloves, like 1 in 3 gloves have holes, right? So maybe you flushed it and it just went into the neck. So anytime that you see any swelling jaw or your patient starts complaining of neck pain on that same side, I would stop or in the ear even, yeah. I would stop whatever's going into it if there is anything. Call the doctor and they're probably going to want an x-ray just to make sure that it hasn't migrated up and out. Anytime that you change the dressing, you're also going to change the caps. And that means not these little blue alcohol caps, but the dark blue ones, right? The ones that we're actually flushing. So anytime you change the dressing, you should change the caps. And then, like I said, anytime I get blood out of it, I usually change the caps too. So that's Cvads in a nutshell. If you guys want to come up and feel these, if you have any questions.